to talk about what is a very timely and relevant topic whenever we think about a lot of T-cell engaging and modifying therapies that we're using now on a routine basis. I do have a couple of disclosures that I want to just inform everybody of, and these are related to advisory boards with Amgen and Pfizer regarding treatments for acute lymphoblastic leukemia. I have other advisory board participation listed there. And importantly today, we will be talking about off-label as well as investigational use of these medications. Before we roll into the objectives, I want to go back in time a little bit to a monoclonal antibody, TGN-1412. This was around 2005, and actually what this was a CD28 superagonist monoclonal antibody that was hopeful for the treatment of acute leukemia. However, they did do a phase 1 dose escalation study in 6 patients before it was halted that actually looked at this drug in patients that did not have malignant disease. They were trying to find adequate dosing strategies. And what we learned is that quickly after infusion with this superagonist molecule, all of the patients went on to develop very significant cytokine release syndrome. Within 1 hour of infusion, we had elevations in a bunch of different cytokines. I have them listed there for you, but some of the more important ones included tumor necrosis factor alpha, interleukin-6, as well as interleukin-10. A lot of the initial reactions were assumed to be associated with the infusion. There were fevers, nausea and vomiting, and headache. But what really happened is within 24 hours, many of these patients had a progression to multi-organ dysfunction, disseminated intravascular coagulation, and many of them required ventilatory support. Patients were treated with corticosteroids, ranitidine, and this was in London, so they were using chlorpheniramine. And luckily, none of these patients died, but obviously, for those of us that are treating patients that are receiving some of these, the more modern T-cell-related therapies, we know that it can take many days after there is recovery in these cytokine levels before the symptoms go away. What we've been able to learn from a lot of the studies that have looked at these molecules is that we can really sort of define the symptomatology and the course associated with cytokine release syndrome now. We know that it can be very, very mild, where patients have relatively few symptoms, not needing any major interventions, or it can be significant. I have a lot of the toxicities listed here for you, and I won't read them all off, but they can affect many, many organ systems, causing cardiovascular dysfunction, hypotension. From a respiratory perspective, patients can become hypoxemic, requiring ventilatory support. And it's often hard for us to discern the neurologic toxicities associated with these agents. Is it because these agents are crossing the blood-brain barrier? Is it because there is cytokine release that is crossing the blood-brain barrier? What exactly is going on there? And so many times there's overlap for this symptomatology. And just before we get started, I just want to clarify today we're going to be talking about cytokine-associated toxicities associated with these agents. So this is going to be the result of lymphoid most often, but can also happen with myeloid activation, where you have a release of cytokines that is non-antigen specific. So we're not going to be talking about on-target off-tumor effects. So the objectives today are relatively simple. We're going to be characterizing cytokine release syndrome that follows T-cell engaging or modifying therapies. We'll be talking about blinatumomab and the cytokine release that follows it, as well as chimeric antigen receptor T-cells. We'll also be talking about different treatment modalities for these patients and what we should be considering as next steps in order to try to mitigate CRS in this patient population. So we will be following a patient throughout today just to see how we deal with some of these cytokine syndromes. This is a patient DE, a 30-year-old male with Philadelphia chromosome negative ALL that was diagnosed in 2014. He was treated with hyper-CVAD for 8 cycles and then went into a first CR. He was placed on pump maintenance at that time, but he did relapse his disease in April of 2015, and at that point in time, he was enrolled on CALGB 10403, or actually treated per that protocol because he had not yet been treated with an adolescent young adult protocol. He did have a second CR, but he remained MRD positive, and as we all know, patients that are MRD positive have a worse prognosis, and so therefore the decision was made to give him blinatumomab. Blinatumomab has been studied in a variety of patient populations that have ALL, including those that remain MRD positive, and 80% of those patients do respond and become MRD negative. So the reason why we may have things such as MRD that even persist is because of a variety of tumor immune escape mechanisms. Typically, our T cells are able to sort of provide surveillance, identifying any tumor cells that may be present and taking those out of circulation. However, there can be changes in the microenvironment. It can become too acidic or too basic. There can be changes in the T cell repertoires that are available. T cells can become quiescent, and there can be expression of lots of different negatory or negative inhibitory enzymes that can sort of depress T cell expansion and function. And finally, we can actually have an overgrowth of regulatory T cells, which are more immunosuppressive in nature. What we've learned over the years, though, is that we're actually able to harness the immune system through a variety of ways, and now we're able to sort of deal with this sort of immune escape phenomenon head-on. We've been able to see the effects of immunotherapies in using stem cell transplantation, vaccination, more recently immune checkpoint inhibitors, but today we'll be talking about bispecific T cell engaging therapies as well as chimeric antigen receptor T cells. So blinatumomab, just to see a raise of hands, how many folks in the room work with blinatumomab on a regular basis? Okay, so this is perfect. Then we can have a lively discussion about that. But as you all know then, it's given as a continuous infusion every day for 28 days of a 6-week cycle. There is a 2-week break. It does require hospitalization for dose escalation. And I won't go through all of the details associated with the mechanism of action, but to be just really quick, it brings the T cell in contact with the CD19 target cell. There's a cytolytic synapse. There is a release from the T cells of granzymes that are actually able to enter the CD19 targeted cell and induce apoptosis in that cell line. Here, the pharmacodynamics are given for blinatumomab. We know there's a redistribution of T cells within the first 14 days, and that the B cell numbers decline relatively rapidly and stay low throughout that treatment-free period. Just like the molecule TG1412 that we've already discussed, we see interleukin 6, 10, and interferon gamma again being relatively elevated over the first couple of days, but then they return back to baseline. And this is when we see most of the cytokine toxicities associated with blinatumomab. Typically, whenever I think about my experience with blinatumomab, I typically think that the CRS that I've seen has been relatively mild to moderate. I have not actually witnessed very significant CRS associated with blinatumomab, but it is reported up to 13% of patients in the phase 2 trial had CRS to some degree. But typically what we see is what appears to be more infusion type of symptoms, flu-like symptoms associated with it. There can be LFT abnormalities, and so we have to be on the lookout for those. I've never had a patient to really become hypotensive where there was an unrecognizable cause for that hypotension to occur. But there are definitely reports of DIC as well as hemophagocytic macrophage activating conditions, which I'm only going to mention briefly because Erica will be talking about those. Because of this cytokine release syndrome, though, there is a black box warning for the use of blinatumomab, and there actually are recommendations for either dose interruption, holding until it returns back to baseline, or discontinuing altogether for grade 4 toxicities or any seizures. So going back to our patient DE, on day 3 of his blinatumomab infusion, he's febrile, having arthralgias, and experiences mild alterations in his mental status. Everything from an infectious workup appears to be negative, and there's no identifiable source of infection. So what intervention, if any, should be made at this time? Should we give him dexamethasone? Should we permanently discontinue the blinatumomab, hold the blinatumomab and reinitiate once at baseline, or should we give him a dose of tocilizumab? Anyway, the correct answer here is going to be to give dexamethasone. For patients that have relatively mild symptoms associated with blinatumomab, we can give them dexamethasone, and we'll talk about the reason why it's possible to do that. Here we would not want to hold or discontinue the blinatumomab because it's just not that significant, and the patient definitely doesn't need tocilizumab at this time. Okay. The reason why we know that dexamethasone can be used with blinatumomab is because we have actually had information from patients that have received dexamethasone during treatment with blinatumomab, and we see that markers of T-cell activation are still present. So these are CD69 and 25. They do not become decreased or diminished after dexamethasone treatment, and they were able to actually note that there was no cytotoxic decline from a functional perspective in patients that received dexamethasone therapy. Therefore, dexamethasone is the treatment of choice, and we routinely give dexamethasone with blinatumomab anyway. We do it at initiation whenever there's the dose escalation or if there is an interruption of therapy. So unfortunately for our patient, he had another bone marrow biopsy after blinatumomab therapy that showed that he had 30% blast. At that point, he did have T cells collected, and he underwent cytoreduction with CAR T cells following cyclophosphamide conditioning, and the CAR T cell infusion was given on 10/25. So chimeric antigen receptor T cells, how many folks in the room are using those on a routine basis? So less. So just to talk a little bit then about what actually a chimeric antigen receptor is and sort of how this works for patients. Chimeric antigen receptors do have a single change variable fragment that is targeted in a particular cell, here a CD19 positive cell. And it's attached to the signaling part of the T cell receptor. There are co-stimulatory molecules that are added, such as CD28 or 41BB. And what they do is they actually take the patient cells, they add through genetic transfer via a gamma retrovirus, the addition of this chimeric antigen receptor into the T cells and then reinfuse them into the patient. So after his T-cell infusion, he did become febrile and tachycardic. He received broad-spectrum antimicrobial therapies, but he did develop encephalopathy that persisted for several days. He developed left arm weakness, and he was transferred to our ICU. And sort of just following along CRP levels for him, he had a very elevated CRP level at 21.5, and his ferritin at that time had gotten to greater than 25,000 nanograms per ml. So we know that CRS is definitely something that happens much more frequently with CAR T cells than bispecific T cell engaging therapies, and we also know that there are a lot of variables that can play into how toxic the T cell treatment is actually going to be. We know that patients that have a higher disease burden, like the patient we're talking about now, is going to have more toxicity associated with that bulkier disease. Symptoms appear at the time of maximal T cell expansion. In my experience, that occurs anywhere from 3 to 7 days following T cell infusion. We know that the better we enhance the CAR constructs via adding these co-stimulatory molecules, the more toxicity we're going to see, because the flip side of having that increased cytokine activity is that we're going to have better expansion and activation of our T cells. We do recommend that steroids be used only when there is severe CRS or if there are signs of neurologic compromise up front, because the thing that we don't want to do is ablate all of the T cells that we have already prepared. And again, for severe CRS, including those with neurologic manifestations, then tocilizumab here is going to be the drug of choice, and we'll be circling back and talking about tocilizumab in just a moment. In terms of the grading of CRS, the grading of CRS has actually been changed and modified from the common cancer or the common toxicity criterias. And now what we really do is we have symptoms lumped sort of into mild symptoms that don't require a lot of intervention to those as the grade increases, there's more oxygen requirements, addition of additional doses or additional vasopressor support, ventilatory support, those types of things. And obviously grade 5 there is death. So whenever we think about all of these things that can happen with patients that actually going to develop cytokine release syndrome, the first thing that pops in all of our minds is, are we able to identify folks that are going to develop cytokine release syndrome? And whenever they do develop it, can we predict how severe it's going to be? And unfortunately, that remains a relatively problematic area for using the cellular therapy. One of the problems is that assays are not readily available. Obviously, places like CHOP and Penn, where they're doing lots of T cells too, have more expanded cytokine panels. Even at Memorial Sloan Kettering, where we routinely use CAR T cells in patients as well, we're really only looking at about 4 cytokines that are being reported from our panel. We also know that the severity of CRS does not always correlate with cytokine levels. And also what we've learned from the results of folks at CHOP and Penn and others is that there may be up to 24 cytokines involved. And so if we don't have the full panel, it's difficult for us to be able to tell. We do use CRP routinely in practice. It is an acute phase reactant that is produced in response to IL-6 production, which is one of the indicated cytokines associated with cytokine release syndrome. It does take about 2 days before we have CRP levels that become very, very measurable. But it's important for us to think about a cancer patient at baseline where there may already be inflammatory cytokines that are elevated, and so therefore it may be more beneficial for us to think about the peak increases and the fold increase in CRP levels, as well as the same sort of thing with ferritin. There's a lot of variability. We just talked about cancer patients and the fact that there may be some variability amongst cancer patients, but it can also vary based on age, gender, ethnicity, the disease burden, the type of malignancies that we're looking at. All the cytokine levels are not always going to be the same. And then you have to take into account if there's any autoimmune disease, infection, those types of things that are oftentimes common, especially infection in this patient population. So transitioning to one of the most important cytokines, IL-6 is a known mediator of CRS. And the way IL-6 works is it's able to bind to the IL-6 receptor. And there are both membrane-bound receptors as well as soluble IL-6 receptors. So once it is able to bind its IL-6 receptor, which is not present on all types of cells, it then couples with glycoprotein 130, which is present on every cell. And then we have activation of that pathway through there. The thing about IL-6, so whenever we get relatively high levels of IL-6, is we have what we call trans-signaling, where it's able to be activated through that soluble IL-6 receptor that is not membrane-bound, and activate the cascade that way. Tocilizumab is a humanized immunoglobulin that actually is able to target the IL-6 receptor, and it inhibits binding of both the cellularly associated, so membrane-bound IL-6 receptors, as well as the soluble IL-6 receptors. So therefore, we're able to blunt the effects of IL-6 in both this classical and a much more profound pro-inflammatory trans-signaling event. It is effective treatment for CRS. Clearly, there's no randomized trial to support the use of tocilizumab, for example, in these patients, but clearly it's being able to sort of block the effect of one of these cytokines is something that was noted early on whenever cellular therapy was started to use. The great thing about it is once you give it, patients start to recover within just a few hours. They become afebrile, and within 36 to 48 hours, you're really downgrading the vasopressor support in these patients. The dose is listed as 4 to 8 milligrams per kilogram, depending what you look in. We always give 8 milligrams per kilo at Memorial Sloan Kettering if we use it. There is actually descriptions of patients that become more refractory to tocilizumab. In fact, they looked at tocilizumab use in ALL patients that were treated with anti-CD22 CAR T cells, and what they found was that the patient that actually was not responsive to tocilizumab actually had much higher IL-2 levels than were predicted, and there was actually no increase in the IL-6 level, so a different kind of process happening in those folks. Again, HLH, I'm not going to spend a lot of time on HLH today, but it does have a variety of symptoms, and what we know is that patients will have ferritin levels that will become elevated. All of the T-cell patients do, but once that gets above 10,000, 10,000 is really a cut point where we start to worry, okay, it's really much more associated with more significant disease at that time. There's expression of macrophage activating cytokines such as MCP1, which are chemoattractant molecules, and MIP1B. And again, this leads to activation, very pro-inflammatory, and can result in organ failure, and tocilizumab is definitely indicated in that patient population. So we've done a lot of different things to try to make CAR T-cell therapy safer for patients. We've looked at the disease burden and tried to modify the dose to be more effective in patients that have bulkier disease. We know that we can give really high CAR T-cell doses, and we'll have really, really good responses. And with that, we get 100% toxicity from those. We know if we go too low on the dose, then we can have decreased efficacy, or what appears to be decreased efficacy. So there are split dosing strategies based on the bulk of the disease. And again, I think one of the most important predictors that we've seen there is, what is the morphologic disease status of the patient at the time of their therapy. There are lots of other ideas that are sort of floating around. Could we use prophylactic tocilizumab? There are not a lot of places that are routinely doing that, but if we were able to identify genes that would put people more at risk, then maybe that is a strategy that could be incorporated there, since we know that it doesn't really affect the T-cell response. Siltuximab binds circulating IL-6. There aren't a lot of actually published data yet with siltuximab, but that certainly could be an option, especially since we know that IL-6 can also cross the blood-brain barrier, and so it would be nice to be able to potentially get that before that happens. Interestingly, there are also has been reported the use of ruxolitinib. Again, this is happening in mice right now, but we know how rapidly things move in patients that are receiving these cellular therapies, so it could not be far away before we're using ruxolitinib to sort of block that whole Janus kinase pathway with STAT activation at the end. Ibrutinib has also been used in combination with CAR T cells, and it's been shown to not only increase the response to CAR T cell therapy, but to also decrease cytokine release syndrome. That was an observation that was seen there. So we have lots of different things sort of in the pipeline. And one of the important things, too, is the use of suicide genes. We actually have a clinical trial that has opened at Memorial Sloan Kettering now. It's actually in patients with multiple myeloma, but it includes a truncated EGFR or EGF receptor, and for patients that are not responding either to steroids or tocilizumab, then the next step is to give them cetuximab, and that in effect will activate apoptosis in those cells. So just going back to our patient, he goes back to the ICU, again, where we left off for management of his encephalopathy. Which of the following should be given to treat his CRS? And we'll see if this works. A is infliximab, B is tocilizumab, C is adalimumab, or D is miromonab. So the answer is actually B, tocilizumab. Tocilizumab would be indicated in this patient. He's already received steroids on arrival to the ICU. Again, steroids are indicated especially in patients that have neurotoxicity, but we would give tocilizumab here due to the progression of his disease. In summary, immunotherapy has revolutionized treatment for many tumor types. Here we're talking about bispecific T-cell engaging therapies as well as CAR T-cells that have actually been able to help avoid some of these tumor immune escape mechanisms. CRS is one of the most important toxicities associated with these therapies, and as we've seen, there's a spectrum of disease here. It can be either relatively mild or very, very significant and profound. The question and the results on biomarkers and the use of cytokines is still kind of out. What we do believe is that the magnitude of the fold increase is going to be more significant than elevations themselves. And dexamethasone and IL-6 receptor targeted therapies are the preferred CRS treatments. And with that, I'll take any questions that you may have. And again, just to follow up, I did skip a little bit of the HLH presentation, so since we're going to be having that, but that is an important, a very important manifestation of cytokine release syndrome.